Good evening. In the last session of this wonderful conference, thank you very much, Dr. Meena and the AIOC for the invitation. So, I'd be talking of post-vitrectomy glaucoma, which is a problem that we face quite often. The intraocular pressure rise following posterior segment surgery could be either early or maybe later. The early rise is most likely to have a persistent rise for about 6 weeks, most commonly due to SF6 or C3F8 gas or silicone oil, or tight scleral buckles and encerclage, or very acute inflammation. But later, it's usually due to prolonged corticosteroid use or damage to trabecular meshwork, which could be pre-existing or could be part of the pathology. So it's important to know what the problem is before we go on to solving it. So the risk factors, this nice case control study I came across, patients who required a glaucoma drainage device after VR surgery, versus patients who underwent VR surgery without a subsequent drainage device. And they found that younger patients, more often men, those who had more interventions prior to the VR surgery, those who were treated with silicone oil, those who had higher intraocular pressure in the first post-operative week, and those who had a history of glaucoma. So these are all very intuitive things as to who would be the one who would likely to require a drainage implant after surgery. So the broad management principles are medical management, especially for an acute rise, and sometimes they may require a buccal removal, silicone oil or gas removal if it's again an acute rise, and chronic rise usually requires surgery, and more often than not, post PPV, we prefer glaucoma drainage devices. So medical management is given first, but the IOP level and vision guide the plan. So roughly when we are in the clinic, if the pressures are more than about 30 and there's moderate vision, we usually think about surgery or a limited diode laser cyclophotocoagulation, depending upon the state of the conjunctiva and scarring, etc. Whereas if it's poor vision, we usually just straight on go on to a DLCP rather than try heroic methods. And this is especially if the other eye has good vision. But if it's less than 30, then we always try with medical management first. And usually if it's the inflammatory or the corticosteroid effect, as that goes down, then the pressures also get all right. But if it's poor vision, again, we start thinking of a limited diode laser. In these eyes, hypotenuse is more ominous, so we need to remember that. And this may trigger a redetachment for a surgery which had been done. So we need to be a little more on our guard when we are operating on these eyes. And usually it's sobering to realize that most patients will be on 1 or 2 medications despite surgery. So the options we have are a glaucoma drainage device, which is useful in very high risk eyes with scarred conjunctiva. Failures occur in about 20%, transient complications in 20%, and severe complications in 20% more. But then without doing it, we've lost the battle anyway. An inferior placement glaucoma drainage device avoids a migration of emulsified particles underneath conjunctiva, and that causes subsequent fibrosis. So if we have silicone oil, a lot of us prefer to have an inferior drainage device. The tube placement in sulcus is easy. It is safer for the cornea, and after cataract surgery, there's no problem at all. If there's pre-existing glaucoma, then usually we might even do a combined surgery, that is a PPV and a tube, which we did here. So if there's an existing encerclage, now that becomes a problem because you might have a pre-existing encerclage, which is difficult to dissect under the muscles, and if you want to place a non-valved implant. So I'll give an example. This 1-year-old, 14-year-old, one-eyed 14-year-old boy lost one eye to blast injury and the other had cataract surgery, recurrent retinal detachments, and then a PPV. Best corrected vision 624, intraocular pressure 44 despite medication, and by now they had very little money left. So mercifully we have the ADI, which is cheaper and we can use. So the problem with the people like this, where I would prefer an AGV anytime, but then the economic considerations come in, and it's very difficult to dissect if you have a scleral buckle in situ. So if you see this, I'll just move this forward. So you see, this is the capsule with the silicone band, and it's very, very difficult to keep on dissecting because you need to place the ADI or the bar welt underneath the muscles. So it takes a lot of time, and you do land up in a lot more fibrosis. And now you can see it's taken a long time to actually dissect out this muscle. And once you dissect it out and make a space for the wing to go in. Now this is a pretty much bulky plate, and you need to have the wings underneath. Usually we'll end up putting the plate over the pre-existing buckle because we can't remove it. So 3 months later, mercifully, his intraocular pressure was 12 millimeters. Best corrected vision is 660. And you can see this inferior tube in the sulcus is well placed. But it's so much easier to just implant the AGV. For instance, this 56-year-old diabetic, if you have TRD, PVR operated but no visual gain, and left eye had PVR and 624 vision but 56 millimeters of mercury. So when we have a scleral buckle like this, I would much rather just put in, and then it's always good to pull out records of the vitreoretinal surgeon so you know exactly where the buckle is, where it's been sutured, so you can plan your device easier. So in contrast to the first one where we struggled and struggled, you see this, all you need to do is slip it over, and what we do is slip it over the buckle and then just take the tube and implant it in the sulcus, because this was pseudophakic. And you can see the silicone oil sitting up there as soon as you lay the patient down on the table. So here the silicone oil comes up, and this is the same thing actually, just the tube being inserted. Right, so post-operatively, you can see there's an inverse hypopion, but because it's an inferior tube, it's not going to block it, it's not going to go out. So it doesn't matter if there's a little bit of inferior hypopion. Mind you, no matter how many times you take these out, sometimes the silicone oil just keeps coming, and you can't keep waiting endlessly. So you need to do surgery despite it. Sometimes it's not enough, and we need to put the second one. So the second one is usually the AGV, which we put. So this is the first one, and this is the other one here. So we have a lot of these one-eyed patients walking around with 2 tubes with good vision, and we just have our hearts in our mouth, and we hope that they sustain their vision throughout their life. Sometimes it can be very troublesome. You do a good surgery, and then there's a big bubble which needs removal pre-operatively. This was interesting. When we learned this earlier, we used to put it as usual in the superior quadrant, and then through the conjunctiva, this is a leaked out silicone oil, emulsified oil. So this is a problem with, but then even with these tubes, sometimes they have it around, and then we need to go in again and do a little bit of vitrectomy and take this out, because pulling it out doesn't work so much. But even then you realize this patient, you had silicone oil emulsified inside the tube. But if the pressures are fine, we just let it be, because there's silicone oil all over the eye anyway. So I'd like to share this video of this patient whose silicone oil came up, and I just wondered with the UBM. So we put it in, and just to see what happens to it. And it's one of the most fascinating UBM videos that I've seen, because it actually shows the current of silicone oil and tells us why no matter what you do, sometimes the silicone oil is just going to keep on and on. And this is the silicone oil which we see here just under the cornea. So sometimes tube migration is a problem. This coloboma RD, one-eyed girl, left phthisis after PPV for RD. So again, the responsibility is even more. So she had right post-PPV glaucoma, but pressure vision of 660. So when we put this, the IOP is 18 on 2 drugs, but then the tube migrates towards the, so this happens in younger children because they rub and all that. So you have to go in again. And here we've trimmed the tube, and this is just right now, and we're just hoping that she maintains her vision. Sometimes with an excessively scarred conjunctiva, you need to swallow your pride as a surgeon and just say that. So what we've learned is that even in adults, a transillumination works well. We just put it on the cornea, and you see how far back the ciliary body is now. If we had the garden variety of 1.5 millimeters behind the limbus, we wouldn't have been coagulating the ciliary body at all. So transillumination, especially in the post-PPV eyes and the younger children, work very well, because it's a very distorted anatomy here, and it's nice to know. So we mark it out, and then we apply the diode laser. So I'll just summarize that post-PPV or a scleral buccal glaucoma is difficult, and many times it is the only seeing eye that these patients have. A GDD implantation is usually required, but for posterior segment pathology and glaucoma, a combined PPV and glaucoma drainage might be a better alternative with pre-existing glaucoma, but sometimes a guarded TSCPC may be a less invasive and a safer option. Thank you very much.